public health, and not just in law and
Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
And today, we have some thrilling news for you.
That's right. Get ready to mark your calendars because we're bringing the conversation to you live and direct.
Join us at the highly anticipated Primary Care 24 event on Wednesday, May 22nd, where we'll be hosting a special live recording of our podcast.
It's going to be an absolute blast, filled with insightful discussions and special guests.
Whether you're a healthcare professional, a policy wonk, or just someone who cares about the future of primary care, this event is for you.
So grab your headphones, your favorite beverage, and head over to primarycareforamerica.org/primarycare24, or just click on the link in the show notes to register for the event.
Don't miss out on this unique opportunity to be part of the conversation shaping the future of healthcare. See you there.
Register now at primarycareforamerica.org/primarycare24. Faisel and I can't wait to see you there. Today, we're talking to Dr. Kenneth Q, founder at EuDoc Direct Primary Care, about Beyond Insurance, the assurance of direct primary care. Let's dive right in.
Hey, Dr. Dan.
Hey, Faisel, how are you?
I am doing great. It's good to see you, as always, and welcome, Dr. Kenneth Q. It's good to see you.
Yeah, good to see you guys. Thanks for having me.
We love direct primary care. We're huge fans of direct primary care. There's a lot of similarities between direct primary care with outcomes-based or value-based care models. So I guess we could start off talking about, for people who are new to this or who don't know or want to learn more about it, like how can the direct primary care approach help reshape the future of healthcare in the United States from our current predominantly hospital-based healthcare delivery system?
Yes, I think to start from just a baseline, what direct primary care is, essentially it's a membership model where we don't take any sort of insurance and the patients pay us directly, hence the name direct primary care. It's usually done on a monthly subscription, flat rate that includes all visits, both in person and virtual. And so how it's different is compared to any other value-based model is that we don't participate with the payers. And in doing so, the underlying principle of it, right, is you're not using your car insurance to fill up your gas or to change your oil. You're not using your house insurance to change a light bulb. So why are we doing it in primary care? A lot of it may be historical, right? When insurance first started, for example, like a heart attack, you would have to spend days in a hospital, hope for the best. But now we can treat hypertension, we can treat high cholesterol, and none of that is really catastrophic care. And so at its core, it's saying, what if we took out from insurance basic primary care, which is chronic care management and some of your basic urgent care, and saved insurance for what insurance is meant for, which is the big, scary, catastrophic stuff. And just by thinking about it this way, I think the direct primary care movement has started to push on a lot of levers in the healthcare system in general.
And that's truly getting insurance to really being insurance, right? I've got car insurance, but I've got an appointment to get the oil changed in my car tomorrow, but the car insurance is not paying to change the oil in my car, right? I'm paying for the maintenance. It's there in case I get in an accident somewhere. And health insurance has gotten to where it pays for, in theory, but when you pay for preventive care, it gets to be so expensive that it gets to be pretty insane. And you all are able to offer lab work and, even x-rays and diagnostic studies so much cheaper than people paying through the insurance companies are.
Yeah, that's right. And that's a great point. So another common feature of direct primary care is our kind of price transparency. We push a lot of price transparency because we get patients kind of agnostic to the payer. We have commercially insured people through their employers, people on health share ministries, and even uninsured, and also government payers. We have patients on Medicare, Medicaid who will pay the direct primary care membership to see us. And because we have such a wide patient base, it's really important in the culture of direct primary care to help navigate the system. So when it comes to labs, a lot of us will offer cash price labs to give general idea, like a complete blood count, which runs in my area around $30 to $80. The DPCs around here do around $5 to $10, right? And that's similar savings across the board, whether it's imaging or labs. We also, some of them, I don't personally, but some of the ones in Virginia will dispense medications at wholesale price directly to their patients, both as a convenience thing as well as a cost savings. So there's a lot of care navigation that happens in DPC that I think a lot of hospital systems and hospital system doctors generally don't think about, but it's kind of forefront to us because instead of spending time chasing codes and figuring out billing and all that stuff, we're focused on what makes the patient experience better.
And you bring up, of course, you don't get Faisel and I started about drug prices and insurance companies and PBMs because it's just there's so many people when you go to get a prescription filled, there's so many people trying to put their hand in your pocket. It's almost insane at this point. Faisel and I are fortunate we get to go to a lot of different medical meetings and hear a lot of people talking. But one of the best meetings I've been to in the last couple of years is the meeting that you and Dr. Mui had. I guess when I did it, it was online. It was just so many people doing so many cool things in primary care. So what is the one thing that sort of you think is really cool that's going on right now in primary care that you just feel a need to talk about?
That's a really big question. Obviously, I'm a little biased towards DPC. I think what we're doing is one of the biggest things. The worlds that I span, and I think I would consider myself fortunate too that I've been able to do a lot of traveling and attend a lot of these conferences. And so I've gotten to meet people in the VBC space and the health tech space and the policy space. I think there's a lot of different things going on. It depends on what interests you have. So I would say from a physician independence standpoint, one of the things that's talked about a lot is doctors unionizing because they have no choice because the hospital systems have taken off. One of the nice things is pushing back and allowing physicians to be independent. So the DPC space is good at that because we have over 2,000 practices. They're all independently owned, independently run by physicians. So that's really cool there. From a tech standpoint, you're seeing a lot of, speaking of AI automation, a lot of things that are allowing us to focus more on just the doctoring, right? The promise that administrators gave a lot of doctors back in the 90s, back when they started taking things over, now tech is doing it without taking over the means of control. AI documentation, just background AI scribes, some automation of processes just to make sure we can keep on top of patients, essentially like following up and watching patients more closely. The value-based thing is interesting. I think CMS with CMMI, they're at least trying, right? They're trying different models, seeing what works and what doesn't work. And I think where we are today, we're learning a lot more about what doesn't work than what does. And it's just fascinating getting to talk to some of the key players in that space and say, hey, why isn't this working? What does work? And again, my bias in direct primary care, I think we have a lot to offer about, hey, what if you just let doctors do their thing and focus on patient care? Let us take it from there. Just a little bit, I would say when we get into value-based care, there's a lot of discussion about risk, right? But risk is an insurance thing. It's not a doctor thing. And I like to say that, let insurance be insurance and then let primary care be your assurance that, we'll take care of you and help you live a longer, healthier life. So it was a little tangential, but hopefully I covered a couple of things.
And you bring up a good point. I don't think any doctors, I was thinking about that not too long ago when I was, it's sort of a tangential story. When I was in Boy Scouts, I went to a jamboree and I liked trading patches. And I was actually pretty good at trading patches, but I realized that I could have spent the entire 10 days or 2 weeks just doing nothing but trading patches. And so what I did is I would specifically decide I was only going to trade patches every other day because I wanted to do the other things that were there. And I realized that I had a knack for not only trading patches, but buying and selling different things and from a business standpoint. But one reason that I was interested in medicine is I thought it would give me a career where I didn't have to be completely consumed and focused on money. But unfortunately, healthcare is now $1 in $5 in the U.S. economy. And if we as physicians don't have some input on how those dollars are spent, the business people are going to come in and try and harvest all of those resources and take them elsewhere. You're obviously almost a full generation behind me as a physician. What are your thoughts about that? How important is it for us to control? I mean, I understand not wanting to necessarily take control of it, but I feel like that's sort of what my generation, we bought into. The administrators were going to take care of the money and we were going to take care of the patients. So it sounds like you want to let the insurance companies take care of the money and you're going to take care of the patients. I'm just wondering, it's still Wall Street handling the money and you handling the patients. And I'm just wondering how that's going to work out.
Yeah, I think, in a perfect world, you let the business people do the business things, you let the doctors do the doctor things. But in context of where we are today, I think every physician needs to have some sort of baseline understanding of where their money comes from, how they get it, who's paying for it. And if they don't want to deep dive and get into minutia, open a practice, that's fine, right? That I don't think that's needed. But especially in primary care, so when I was a fourth year med student, I first learned about the model. A lot of people are like, "How dare you make the patient pay money for your services?" Right? As if it was some sort of like ethical wrong that patients were paying money to a doctor. But then you start thinking about how they pay so much in premiums and then have high deductibles and can't get care anyways. They pay taxes for government programs which undervalue primary care and lead them to the ER. And that really like reframes the picture for you. You start thinking, okay, what is my value? Why do these payers not value me? How can I make it so that patients see it, understand it, payers see it and understand it? One of the things that DPC is doing is we set our rates based on the market, right? Whatever patients are willing to pay us. And that kind of shows the insurance companies like, hey, if you don't value us, if the government's not valuing primary care, well, the patients do. So even if you're not paying for it, they will. They're coming because they understand what we do. I think early on in the pipeline, there's a lot of focus on students. And I talk to medical students and residents now, and there's an increased appetite for understanding the business side because everybody hears on the news or through their professional societies, healthcare is expensive, healthcare is broken, all this money going somewhere, and nobody understands it. And people want to because people want to fix the problem. And I think the biggest problem right now is not so much the medicine and the care, it's the financing and the delivery models.
We were in Chicago at FMX over the weekend, and one of the topics that came up, especially with some of the residents, is, well, why won't the hospitals, why won't the insurance company, why won't the government just give the primary care, give family medicine the control? Why aren't they just giving it away to us? Like it's the right thing to do. It's a genuine question, but you answered that. They're not going to just give it to you. You have two ways forward. And what I've been saying, when I hear you speak, I mean, it really reminds me about the two arrows being, struck out of the bow. You've been shot out of that bow, that fee-for-service bow. There's no going back to that. But me and Dr. Dan, we still have a string attached to the bow. And so the two ways, we have to take it back. This is the only way. And for those who are willing to pay and they can have that relationship, it's a great way forward. But right now, the cost of health insurance, the cost of benefits now for a family of four is approaching $20,000. Unbelievable. We're paying $20,000. Number one cause of bankruptcy is medical debt. Half the people who declare medical debt had health insurance. So no one is just going to give it to us if they don't value what we're doing. So I see two ways forward. Either you do it through the full risk model or through direct primary care. About the monthly membership, that is something that comes up oftentimes with me too when I speak about direct primary care. But then I come back to telling the people that direct primary care practices cost less than what I get my lawn paid. I pay my lawn mowing guy more than what I would pay a direct primary care doctor here in Tampa. So I'd like for you to talk a little bit about the doctor-patient relationship in the direct primary care model, how DPC actually prioritizes that relationship and giving care that's not cookie-cutter medicine. like really giving truly personalized care that's unbiased, not made by some recommendations from some associate, these different recommendations we have. I'd love to hear more about the doctor-patient relationship in the direct primary care model.
Yeah, absolutely. Thanks for that question. I think first, you mentioned the monthly membership and the cost. A lot of people will conflate direct primary care with concierge being upwards of 2,000 to as crazy as 50,000 a year, whereas direct primary care, the national average is give or take $80 a month, and it varies on area, right? In the more rural areas, it's as low as $50 per patient per month. In terms of the doctor-patient relationship, I think one of the coolest things about direct primary care is that when you remove insurance, there's two things that you get rid of. One, the administrative burden of having to file and then chase claims and payment. And two, all the so-called quality metrics that a lot of payers will force on you. In terms of the payment, because it's kind of recurring monthly, it changes the psychology a little bit, right? Because instead of patients thinking every time they go to the doctor, oh, how much is this going to cost? Do I really need it? Do I want to do it? They're like, well, I'm paying already. I might as well just go. One of my patients told me before he would always think twice or thrice before going or even trying to talk to his doctor, but now he finds every reason to engage with me. I think that's right? In primary care, you want to get things early. You want to get on top of chronic disease, on top of the easy urgent care stuff so that it doesn't become something crazy later. And then number two, the check boxes. I think there's a logic behind why they exist, but as we all know, they fundamentally break down when you are actually trying to practice. For example, back when we were tracking A1Cs really tightly, then you get into a game of like, okay, I want to get the new onset who I can bring down versus the like more chronic higher A1C. You start to cherry pick, and then maybe the patient wants to talk about something else. Maybe there's something going on from a social standpoint. They're having some life challenges. That's why they can't get their A1C down. Maybe their meds are expensive, but you're just so frustrated by not being able to get the number down. Or, I had some patients tell me that they went in for a checkup, or I think it was actually a sick visit, and their doctor spent the whole time just talking about like colonoscopies and vaccines and didn't even like address their issue. When you have these burdens, when you have this game, it makes it hard. Whereas in DPC, it's just the patient, and you just do the best for health maintenance, for preventative care. And a lot of people say having a DPC doctor is like having a doctor in the family. Right. It's a little more relaxed, a little more casual. They can text us. They can talk to us for, a longer period of time about whatever. And we don't have these external pressures to meet certain metrics in order to get a certain, reimbursement.
There's so many alignments with what you're saying and the full risk model and value-based care. We obviously, if the care delivered by the primary care delivery system is inefficient, it results in a horrible patient experience and higher medical costs. When anybody else is doing primary care, it costs more money. If primary care is done in the emergency room setting, it costs more money. So we have a financial incentive, right, to keep primary care being delivered in the right place at the right time. And it's that financial incentive. But with you and those in direct primary care, if the patient has a membership with the primary care doctor, I mean, you would not, the patient wouldn't expect it, and you wouldn't let somebody else provide primary care. You wouldn't let an orthopedic surgeon do a steroid injection in the shoulder or the knee. I mean, you'd be doing that yourself.
That's right. We still will use specialists when we need them, right? We're not trying to take over complete care, and there's scope of practice and all that. That being said, we do try to minimize referrals, because it's all about value of the membership. At the end of the day, the core incentive in direct primary care is the patient experience. If you're constantly referring them out for everything, eventually they're going to be like, what am I paying you for? What is the point of this? Right. So really, we want to make sure that the patient has a good experience and that we actually provide the value that they have that they see in us. That's kind of why it's important. Of course, there's a lot of people, you're in the full risk space. They're like, oh, how can DPCs capture the money they're saving downstream? How can they like mitigate their risk or take advantage of the savings? And to us, it's not interesting, right? We don't care about that. Again, it's just giving us room to do what we're trained to do. And then again, let insurance deal with risk discussions and calculation, and we just do what we do.
But you're making a good point there. I was talking to somebody interviewing for a job with us, and he was talking about what happens when patients get admitted to the hospital. And, depending on the market that we're in, in some markets we have our own hospitalist, and some markets we contract directly with a group of hospitalists, and some markets we use the local hospitalists in the hospital systems. It just depends in those areas what we can do best. But the point I made to him is it's not really about the cost of the hospitalists themselves, what they're charging. It's really how they're managing the other resources in the system. It's interesting. You think about the cost of healthcare and you think, oh, those doctors are making so much money, but really the doctors are getting 20 cents of the healthcare dollar, something like that. The rest of it's going someplace else in the system. And so what you really want is you want the best doctors, not the cheapest doctors, right? Because you wind up saving more money by having better doctors, even if you wind up paying a little bit more. If you wind up paying a little bit more for the direct primary care model, that in the long run is likely to save you a lot of money in your interaction with specialists, your interaction with diagnostic studies, and those kind of things.
Yeah, absolutely. To both your point and what Faisel said earlier about incentives, there's a reason everybody's buying up primary care, right? Everybody wants to own primary care, whether it's large corporations, hospital systems, and another form of primary care that's super popular right now is urgent care. They're popping up everywhere. Why? Because when you control primary care, you control downstream spending. For us, we think about direct primary care as an investment, right? You're paying the doctor directly so that the doctor kind of navigates and goes to bat for you. If you go to an urgent care or a lot of hospital-based primary cares, it's a funnel for that system, right? They get you and they're like, oh, you have this one minor thing. Let's get you to this specialist. Let's do this imaging, this lab. And then all of a sudden you're just getting bounced around the hospital system, and they, take a couple cents out of your pocket every time you interact with something, and it becomes an issue. So for us, we think about a direct primary care membership as an investment in your health, an investment in taking care of the wellness side, as well as helping you navigate downstream. I believe it was Harvard Medical School did a study a month ago that showed that hospital-based primary care increased costs for patients compared to smaller groups and non-hospital-based primary care. And, it's pretty obvious to see why, because, you just look at the incentives and that's how it plays out.
Well, I know it was interesting. I was at the FMX and somebody was asking me how much of the continuous glucose monitors we use. And for the patients that are fairly difficult to control and some of the ones on insulin, we use it where it's necessary. But this doctor was trying to tell me, well, we should probably have everybody using continuous glucose monitors, even the people that are pre-diabetic. And I'm like, really? Where'd you hear that? And they said, oh, I heard that from the company that makes the monitors. Do you want to come talk to them? And I'm like, no, I really don't. Right? It's like going into the car dealership and ask them, do I need a new car? Well, of course you need a new car if you're in a car dealership. But right. Realistically, to get a reasoned advice about where to spend your resources, and honestly, people probably, we usually used to say that a person's home is their largest expense over the course of their lifetime. I haven't even thought about this. We probably need to do the numbers. I bet a person's healthcare is approaching the largest expense people are going to spend over the course of a lifetime. And the question is, do you need a financial advisor to help you with those expenses? And is direct primary care that financial advisor to help you there?
Yeah, I mean, especially because this is recorded, we don't have any sort of fiduciary responsibility, right? Again, at the end of the day, we kind of set our prices based on market and then do everything we can because it's baked into our culture to help navigate, help reduce referrals and all that. And hey, if you save long-term, great. The other thing is we try to say, hey, get an insurance product that makes sense for you. And for most people, that's a high deductible health plan, right? If you have read Nudge by Richard Thaler, Nobel Prize winning economist, he actually has a little chapter about health insurance and how it's kind of silly for anyone not to have a high deductible plan, right? Because in the long run, the way the finances play out, that's just better. So yeah, I mean, it's expensive. And to your point about, maybe paying more for a better doctor, I don't necessarily think that has to be true, right? There are a lot of people who are actually saving money by having a direct primary care, whether it's saving through premiums or, again, downstream spending. So ultimately, it's complicated, right? It's healthcare. It's not going to be an easy answer. There's not going to be an easy way to measure it or talk about it.
Well, and I think if you go back to the Atul Gawande article about McAllen, Texas, back in when the 2013-14 timeframe, looked at the cost of healthcare in two different communities that were geographically fairly close together, and the cost of care was markedly different between the two, but outcomes were no different. So more expensive doctors and more expensive healthcare doesn't necessarily buy you better outcomes, right?
Yeah, that's right.
Now, that's a good point. I wouldn't want somebody to think that I was saying. All I'm saying is the cost for the doctor is not the primary consideration when you're looking at managing outcomes and costs. But that you bring up a good point. We don't want people to think that, well, you just go buy the most expensive doctor is going to give you the best outcomes, because that's not going to be the case.
Yeah. I wanted to touch on what you said about CGMs, the continuous glucose monitors, because one thing that's really fascinating in the primary care space, especially when I'm in the health tech communities, is the consumerization of healthcare. All these direct-to-consumer companies who, prime example, Ozempic. You see all the ads on Instagram, Facebook, billboards everywhere where you can just get Ozempic. Big companies, even Weight Watchers has moved into the space. It's hard, right? Because you and I were both, Dan, you and I were both at the Primary Care 23, and there was talk about low value care, right? And all these studies and kind of putting constraints on doctors to not do these things. But one of the harder parts is if we say no, like, no, you cannot have this, no, you cannot have that. Well, these companies exist. They're just going to leave, and then they're going to do that. So that's where I think it's so important to have a doctor-patient relationship, because most people are rational. It's just you don't have time to explain sometimes, and people get frustrated. They're like, oh, yeah, it's just big medicine. They're keeping up a wall. They don't want me to get this thing so that they can keep treating me with medicines. But if you sit down and you say, like, hey, here are the benefits, here are the risks, here's the costs, like, this is why these companies are pushing it and why I don't recommend it. Or sometimes you say, like, hey, it costs this much. If you're willing to pay it and you want it, here are some of the risks. Do you want to do this? And so I think, again, we're a little more flexible in the direct care world because we do have these longer conversations with patients, and you kind of really get to understand why they want some of these things, and you can help them navigate it a little better and kind of fight some of these larger forces that may be trying to just sell them things for the sake of selling them.
Dr. Q, I'd like to ask you, about some of the different arrangements. There's direct to individual relationships, but there are also the direct to employer relationships. Are you involved in one more than the other? And have you noticed a difference with a direct to individual versus a direct to employer relationship?
Yeah, it's pretty fascinating. So me personally, because I'm in Euro practice, I'm still working on the employer portfolio and trying to solve it. Virginia is kind of a nascent market for that and still trying to educate and get out there. But you look at states like Colorado, Oklahoma, Texas, North Carolina, South Carolina, DPC is just exploding out there in the employer space because you get a couple, they talk, and then more and more people sign on. It is interesting because when I started in the DPC space back in 2017, working with employers was like a taboo subject. There was this like side room at the summit where some people were talking about it, but nobody attended. But now it's front and center, and you almost have to at least consider it when you start a practice. And so largely when we talk about the employer space, you're talking about, there's two ways to do it. You can either do it one as like a perk. It's not part of the healthcare spending. If you're under 50 and you don't have to offer anything, some employers will pay for part of it or all of the membership as a recruitment and retention tool. And then when you get to the larger size, either level funded or self-funded employers, you serve as the base. And because I guess it's technically risk sharing for them, but it's their money. And if they do well, then they get to keep some of it. We serve as a base because the promise we make is if you use us, first of all, we don't generate claims. And second of all, we're going to keep your people out of the ER, out of the urgent care, out of high expense care. And so even though the patients aren't paying for it directly, there's still this accountability because the person who's paying for your membership, you still have to maintain that relationship with, and you actually have to deliver. It does get a lot more complicated with employers because some will ask for outcome measurements. They'll ask you to prove that you're actually doing something and you're saving them costs. And that's where the benefit advisors, the real, forward thinking ones in the space who can work with you and help pair you with these employers and then create the wraparound with the transparent PBMs, the independent TPAs, and really build out this plan that doesn't hinder what you do and can actually show the employer over time that they're actually saving money by having you at the foundation. So it's a very different world, but it's one where DPC does well because, again, it's all about incentives and cost savings down the line. We don't ask for any of the money we save the employers. We just ask to maintain the relationship.
Oh my gosh. Well, Dr. Q, thank you so much for taking the time today, talking a little bit more in detail about direct primary care. I think we dug in a little bit more this time than we have before. Thank you so much. And I hope that anyone listening that today's episode helps shed some light on how the direct primary care model can really drive the change, a lot of the change that's necessary. Because Dr. Q mentioned early on, there are people who have no health insurance. They're employed people who just don't have health insurance. There are people who have government insurance, who have direct primary. I mean, there are people with all different funding that are in these direct primary care relationships. And I know I'm a big believer that this model can definitely lead the way with transforming healthcare for the better for everyone.
Thanks so much for having me on.
What are your thoughts on beyond insurance, the assurance of direct primary care? You've heard ours. Now we want to hear yours.
And don't forget to mark your calendars because we're bringing the conversation to you live and direct.
Join us at the highly anticipated Primary Care 24 event on Wednesday, May 22nd, where we'll be hosting a special live recording of our podcast.
It's going to be an absolute blast, filled with insightful discussions and special guests.
Whether you're a healthcare professional, a policy wonk, or just someone who cares about the future of primary care, this event is for you.
So grab your headphones, your favorite beverage, and head over to primarycareforamerica.org/primarycare24, or just click on the link in the show notes to register for the event.
Don't miss out on this unique opportunity to be part of the conversation shaping the future of healthcare. See you there.
Register now at primarycareforamerica.org/primarycare24. Faisel and I can't wait to see you there.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.